Hello, and thank you for joining us. Our project is increasing the utilization of a hospital's power plan, focusing on best practices and quality improvement. As a quality improvement program, our question really comes down to what happens when best practice is not practiced. Now, before we begin, a little bit of background, and this is going to come in three distinct points. First, prescribing naloxone to patients at high risk of opioid overdose is considered best practice by the United States Department of Health. Second, research shows that patients who receive naloxone may actually successfully use it on someone else to reverse an opioid overdose, such as a family member, friend, or an acquaintance. And third, as of June 2019, licensed New Mexico providers are required to co-prescribe naloxone with opioid prescriptions of 5 days or more. Now, something else that's important to understand here is that the University of New Mexico Hospital has two electronic medical record order sets, called the buprenorphine induction power plan and the opiate withdrawal power plan, which were both developed to provide treatments to patients with opioid use disorder. However, we found that neither order set had the option to co-prescribe naloxone, and both order sets were very underutilized, resulting in missed opportunities for prescribing naloxone to patients at opioid use disorder, which led to missed opportunities for the best practice. So our aims were twofold. First, to add naloxone prescription to order upon discharge for both power plans. And second, to increase the usage of both plans by at least 50% over 3 months. This project improves patient safety in a few different ways. First, by integrating evidence-based clinician support into the EMR. Second, by creating a novel method to connect inpatient order to an outpatient prescription, which reduces barriers such as transportation. Both of these measures increase the likelihood that patients will actually receive naloxone after a hospital discharge. And lastly, we address an institutional quality goal, which is to prescribe naloxone with opioids and help providers comply with the new New Mexico law. Our methods are as follows. We did 4 PDSA cycles, or Plan, Do, Study, Act cycles. The first cycle, we reviewed the power plans and we identified that naloxone was not included in either. And we also surveyed providers, which we will go over further in the results section. Our second cycle, we surveyed family medicine, internal medicine, and advanced practice providers from various specialties by administering red cap surveys regarding their knowledge of the opiate withdrawal power plan and their prescribing practices of naloxone to patients at high risk of opioid overdose. In our third cycle, we collected data on the pre-intervention usage of both power plans. Then our intervention. We added naloxone to both power plans, and then we held informational sessions highlighting the power plans as well as the addition of naloxone to both power plans for family medicine, internal medicine, and advanced practice providers. Finally, our fourth cycle, we collected data on post-intervention usage of both power plans. Now if you look to the results section, we have 2 subsections under this section. The first is section A, which are our survey results. First question we asked providers was, do you believe that it's important to prescribe Narcan to patients with opioid use disorder upon discharge? Overwhelmingly, 94% of providers said yes. Then we asked providers, of the patients that you treated with opioid use disorder in the last month, what percentage did you discharge with Narcan? Now, as you can see, there's a discrepancy between what providers believe is important and the actual prescribing rates of naloxone, with only 11% of providers saying that they did this more than 75% of the time. So then we asked them, what prevented you from using the opiate withdrawal power plan? And we found overwhelmingly 60% of providers said that they simply didn't know that the power plan existed. The second part of our results over in section B are actually the usage. The OWPP is the opiate withdrawal power plan usage. Pre-intervention, it was used 4.1 times in 30 days. Post-intervention, it was used 11.5 times over 30 days. This is a usage increase in 180%. So just to re-go over our results one more time and tie it in with the methods. First, we found that they did not know that the power plan existed, which is why we held the informational sessions to highlight the power plan as well as the addition of naloxone. And after those informational sessions, that's when we got our post-intervention data and saw an increase in usage in 180%. So our conclusions are that a student-led quality improvement program is helping providers adhere to co-prescribing laws in New Mexico. We're also increasing provider decisional support through the EMR Power Plan, and we're maximizing patient safety. We were also able to successfully link an inpatient power plan order for naloxone upon discharge to an outpatient pharmacy. We're very hopeful that future data analysis will show an increase in the rates of naloxone prescription due to this change. Our research really highlights the importance of ensuring that providers are aware of existing power plans at their institution and that the power plans meet the standard of care so that they can be properly utilized for our patients. Our findings also demonstrate the power of quality improvement initiatives to identify areas of improvement and actually affect change. In the future, what we hope to do, we would like to obtain pre and post data for the buprenorphine induction power plan, which we have not been able to get yet. We would also like to obtain naloxone prescription rates pre and post intervention to see if they increased. And lastly, we believe that we should conduct some refresher informational sessions for various provider groups to ensure the continued utilization of these power plans. Below are our acknowledgement and references, and we thank you for your time.